You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 11th, 2024. This week, listener feedback on cardiac devices and PFA, a new paradigm in the language of MI, sudden cardiac death, and blood pressure. First, listener feedback on cardiac devices. On the September 20th podcast, I reported on a survey observational study from Harvard that was published in the Annals of Internal Medicine. The study reported sobering results regarding cardiac device approval. The authors focused on Class 1 recalls, the worst kind, from 2013 to 2022. They noted 137 recalls involving 157 devices. To review, nearly 3/4 were moderate risk devices that were approved through the softer 510K pathway. The most important finding was that most studies of devices used surrogate and composite measures as primary endpoints, as well as these studies being non-randomized and open label. Only half of the pre-market approval devices had required post-approval studies, with 14 of these reporting delays, and get this, no 510K approved devices were subject to post-market surveillance, none. So the senior author, Dr. Kushal Kadaki, I think, sent me an email summarizing the main findings, and these were that it was surprising to him that most cardiac devices that had Class 1 recalls were approved through the much less rigorous 510K pathway, and that means that the device only has to be shown similar to previous devices. I would add here from my memory that the company called CentraHeart first received a 510K FDA approval of its Lariat device, get this, for suture-based soft tissue approximation. But, come on, Lariat is a far more complex device than a suture-based soft tissue approximator. So Dr. Kadakia added, additionally, over half of the PMA devices were so-called supplements, meaning that testing was not required. The reason this was important is that there's an ongoing GAO investigation requested by Congress, and it's specifically focused on how the design of regulatory pathways, the PMA pathway and the 510K pathway, affects the risk of recalls, and that this work that they did provides empirical evidence for these policy reforms. He added that the significant lack of post-market surveillance is a sub-finding that further reinforces the need for unique device identifiers, which Dr. Emanuel highlighted in his editorial. It was shocking to him that we do not have any standardized method of tracking devices in the real world, and proposals to advance these UDIs, unique device identifiers, onto claims are currently stuck in the HHS bureaucracy, with the obscure advisory committees currently blocking adoption to the detriment of patients and clinicians. Again, my friends, I would add, please be careful with new devices. Some of these things are advances, but this paper and this feedback reiterates that we should not rely on our regulatory system because our regulatory system is not rigorous. All right, I also received some short listener feedback on my PFA talk. I spoke quite favorably in terms of PFA with my early experience. So I've been skeptical. The empirical data is kind of weak, but I started using it, and it's quite remarkable. I did 4 PFA cases this week, and it is kind of remarkable. Well, Dr. David Ferrara from Australia wrote via email. He says, I also love the PFA technology and I'm excited about its future, but I am not certain that there is no risk of atrial esophageal fistula with PFA as the companies would have us believe. He noted a few observations. First, it took many years of RF ablation before we noticed the first atrial esophageal fistula. He also said that cryoballoon was also marketed as no risk of atrial esophageal fistula. However, we now know that that can and does occur with cryoballoon. And Dr. Ferrara pointed to the ADVENT trial, which has shown that PFA can cause phrenic nerve injury. Therefore, it cannot be completely cardioselective. And finally, he cited a paper that showed that PFA can indeed increase esophageal temperatures, and I will note that in the show notes. So Dr. Ferrer concluded that he suspects that there still may be issues with atrial esophageal fistula with PFA, though probably less likely. Time will tell. I love this comment because it kind of reiterates the first listener feedback topic I just noted about the lack of rigor when it comes to regulating new devices. It is true that PFA is new, but I suspect that PFA proponents would point to the fact that Europeans have been using it for at least 2 years, and we have not yet seen reports of esophageal injury. That said, I would remind everyone that PFA is merely a new way to do PVI and to destroy atrial myocardium. It adds nothing to the knowledge base of AF pathophysiology, which is the core issue in treating 90% of patients with AF who do not have focal AF coming from the pulmonary veins. All right, next topic is one of the more important things I've covered in this podcast. This is towards a new classification of MI. The new journal, JACC Advances, has published a state-of-the-art review paper on the clinical implication of the terms STEMI and non-STEMI. And central to this story is reading EKGs. That's the main reason I went into cardiology many years ago. ECGs, the beautiful ECG. Now, under the radar for decades, we have adopted a paradigm which simply stated goes like this. ST elevation on the ECG of a patient with chest pain equals a coronary occlusion. That puts the person on the emergent PCI train, and with this comes the quality metrics of door to balloon time, and everybody just gets on the cath lab train. But a patient with a similarly classic chest pain, whose human reader of the ECG does not declare ST elevation, is diagnosed with non-STEMI, and that patient is not placed on the emergent PCI train. Now, the problem with this paradigm is that many patients with non-STEMI actually have an occluded coronary and thus would benefit from emergent PCI. This, my friends, is the false negative problem. Additionally, some patients with ST elevation do not have an occluded vessel. The false positive problem is not going to be as big a deal as delayed opening of an occluded artery that's causing myocardial damage and not reversed. The 5 authors of this paper, first author Jesse McLaren, argue that the STEMI paradigm, which has transformed emergency cardiology and been ossified into dogma for decades, too often fails. The authors cite the late scientific philosopher Thomas Kuhn, who wrote that science revolutions begin by a growing sense, often by a small subdivision of a scientific community, that an existing paradigm has ceased to function properly. They propose a new way of thinking about the emergency management of chest pain, and core to this new thinking is a new language. Rather than triaging patients in the emergency department with chest pain into STEMI or non-STEMI, they propose a paradigm of thinking about occlusion MI or non-occlusion MI. Now, the ECG revolution, I remind you, began with Q waves being diagnostic for MI. Then came ST elevation and injury, but now the mostly emergency medicine authors propose making the diagnosis of occlusion MI or non-occlusion MI. Occlusion MI patients benefit from emergent PCI. The authors begin their persuasion piece with logos, statistics. First, about half of patients with acutely occluded coronaries do not exhibit ST elevation. Nearly 1 in 3 patients diagnosed with non-STEMI have acutely occluded coronaries. And this is really sobering. Less than 10% of patients having a very high risk non-STEMI have PCI in under 2 hours. Less than 10%. They then explain something called incorporation bias, and I hadn't heard of this before. Incorporation bias occurs when the index test, the ECG, is mirrored by the reference test, the angiogram. The bias skews the diagnostic framework because it obscures false negatives and perpetuates the no false negative paradox of the STEMI paradigm, and here's how it happens. Here's the story. A patient with STEMI goes to the lab, and if he has an acute coronary occlusion, then it is a true positive, a STEMI. If there is no culprit, say it's Takotsubo, then it's a false positive. But if the ECG does not meet ST elevation criteria, and the patient does have an acute coronary occlusion, this is not considered a false negative because it is by definition a non-STEMI. Now, despite a new wall motion abnormality, peak troponins, the harm of not intervening, the discharge diagnosis remains non-STEMI, even though it is a clear failure of the STEMI paradigm. The authors then show numerous ECG patterns that indicate an acute coronary occlusion but are often missed and called non-STEMI. Please go look at their table 2. It's really worth a look. We see these patterns in peer review committees at our hospital often. The ST elevation and bundle branch block pattern, the hyperacute T waves, the ST elevation in 1 and AVL, the inferior ST elevation that is subtle and noticeable only because of reciprocal changes in AVL. These are all in table 2. Now, they conclude by proposing 4 ways to change the STEMI, non-STEMI paradigm. First, mainly language. Think in terms of occlusion MI and non-occlusion MI. Second, is to shift the medical record. Rather than calling patients STEMI or non-STEMI, the record should reflect occlusion MI or non-occlusion MI. And if you have this distinction, quality initiatives and education can advance. False negatives can now be recognized. I totally agree with the authors who state that if we start calling non-STEMIs due to an occluded coronary, if we start calling these missed occlusion MIs, behavior would change quickly in the triage process. Third, the 2 above changes should lead to a change in a code STEMI language. Now we have a code occlusion MI, or we have acute coronary occlusion call teams, or OMI teams. Of course, this would require the 4th and the hardest means to change. This would require improved diagnosis in the ambulance or in the emergency department. To me, having been trained in ECG reading at Indiana with Dr. Charles Fish and having moonlighted at the busy St. Vincent's Hospital in Indianapolis, none of the patterns that they show in Table 2 of this paper look subtle to me. Those ECGs just scream occlusion MI. I am told, however, that young clinicians don't have these patterns burned into their brains. But part of the reason that they don't, I think, is the lack of feedback on ECGs. So rare is it that missed occlusion MIs get reviewed because they have the label non-STEMI. Therefore, changing the language immediately improves education. You don't have to miss many of these subtle AVL changes to start seeing them again. AI programs, machine learning, like the Queen of Hearts application, will help. So will better skills with point-of-care ultrasound, wherein a wall motion abnormality can be seen. Examining the heart with our eyes rather than our ears is surely going to help this paradigm change. But I think the main force improving the diagnosis of acute coronary occlusion comes from changing the paradigm. Once we teach clinicians to think occlusion MI versus non-occlusion MI, gone is the safety of the non-STEMI diagnosis. This changes our priors, which then affects the posterior thoughts after the test. This may be the most important topic I have covered in a long time. Occlusion MI, not STEMI or non-STEMI. It's time for a Kuhn-like scientific revolution. All right, third topic, speaking about changing paradigms, let's now discuss sudden death after MI. My gosh, a new paper in the European Heart Journal makes me stop and think about the old versus new ideas regarding the primary prevention ICD. The first author of this paper, Neil Peake, writing for the PROFID authors. Now, PROFID is a provocative RCT of ICD versus no ICD in patients post-MI with left ventricular dysfunction. Profit attempts to replicate the MADE-2 trial in the modern era. The idea behind this observational study, published in European Heart, was to see whether use of LVEF and of a broad spectrum of other predictors allows identification of low-risk patients with severely reduced EF that don't need a defibrillator, and or high-risk patients with only mildly reduced EF as candidates for targeted defibrillator implantation, basically risk stratification. Now, this work is part of the larger PROFID project. Their analysis pooled 20 data sets, 140,000 post-MI patients, and the data sets could be from observational cohorts such as the Swedish Heart Registry, or it could be from RCTs like MADE-2 or SCUD-HEFT. And the authors analyzed and made three main groups of post-MI patients. Group 1, patients with LVEF less than 35% who received an ICD for primary prevention, and these were the, quote, ICD patients. Group 2, patients who did not have an ICD after MI, they were called non-ICD patients. And in this latter ICD group, they separated the analysis for patients with LVEF less than 35%, and they were called non-ICD patients less than 35%, and the second group was LVEF greater than 35%, and these were called non-ICD patients with EF greater than 35%. The primary outcome was sudden cardiac death, but in ICD patients, the surrogate for sudden cardiac death could also be, or pretty much has to be, appropriate therapy for VT, like shocks. They had two phases of the study. One was to assess the predictive performance of ejection fraction for sudden cardiac death, and in the second phase of the study, they assessed whether parameters of CMR, SCAR, improved prediction of sudden cardiac death over ejection fraction alone. So the results, they had about 7,500 patients with an ICD, 25,000 non-ICD patients less than 35%, and 107,000 non-ICD patients greater than 35%. The 3-year rates of sudden cardiac death were, in ICD patients, 18%, in non-ICDs less than 35%, 3.4%, and in non-ICD patients with EF greater than 35%, less than 1%, 0.9%. They found that left ventricular ejection fraction was a poor predictor of the primary outcome in all three patient subgroups. Upon external validation, get this, LVEF as a sole continuous predictor had a C-statistic of 0.50 for the risk of a first appropriate defibrillator therapy at 3 years in the ICD patients, 0.53 for the risk of sudden death in non-ICD patients less than 35%, and 0.56 in the non-ICD patients with good ventricles. Now, by the way, you all know 0.50 for a C-statistic is a coin toss or no prediction. And in the phase 2 analysis, they had MRI images available in about 2,000 patients, and upon external validation, the predictive performance for the primary outcome at 36 months, achieved by the model consisting only of LVEF, age, and sex, was almost identical with the predictive performance achieved by the model that added MRI findings. And the authors concluded that, quote, more accurate risk stratification for sudden cardiac death and identification of low-risk individuals with bad ventricles or high-risk individuals with preserved ventricles was not feasible, neither using LVEF nor using other predictors like CMR. Wow. Comments. These are remarkable, provocative findings. Left ventricular ejection fraction with a C statistic not much better than a coin toss. CMR added nothing. That's not how we have rolled for the past 20 years. Now, you recall that back in the day, there were many papers that looked at risk scores that could predict the value of the ICD. I'll link to a couple of these, but the bottom line is that either using basic clinical factors or CMR, you could predict patients that have a high risk of sudden cardiac death after MI, and therefore, clearly those patients would benefit most from an ICD. But that's not what this paper, which was a huge analysis looking at observational data and RCTs, found. Now, perhaps it was because this study had 100,000 plus patients, perhaps because they included ICD and non-ICD patients with good and bad ventricles. I don't know. Another note on a specific finding of this paper. At 3 years, 18% of ICD patients had received therapy for VTF versus only 3.4% sudden cardiac death rate of the non-ICD post-MI patients with ejection fractions less than 35%. So ICD patients, 18%, ICD eligible patients that did not have an ICD, 3.4%. Why does the ICD cohort have 5 times more events? One reason, I think, is that many ICD shocks do not represent life-saving events. And we saw that with the permissive programming, letting VT go longer, for instance. This improved outcomes. The Made It RIT study is the reference for this comment. Now, anecdotally, those of us who implant and follow ICD patients can testify to the findings of this paper, right? I've placed ICDs in people with terrible ventricles, class 3 heart failure, fragmented, scary-looking QRS complexes, and that patient never gets a shock. Similarly, I put in ICD patients with ejection fractions of 34.999%, never above 35, and these patients can go and have VT storm. I report on this paper because it makes us stop and think and question our beliefs. This finding, plus the falling rates of sudden death in heart failure patients, plus the improvement in medical therapy, and the risks of the ICD provide the equipoise necessary to support the PROFID study, the PROFID RCT. And again, I cannot congratulate the PROFID investigators enough for having the scientific rigor and bravery to question the value of the primary prevention ICD. Finally, I agree with the authors who write that in patients with an EF greater than 35%, the lack of any acceptable accurate risk stratification tools combined with the very low sudden cardiac death rate questions the feasibility of attempts at identification of high-risk candidates that would benefit from a defibrillator. Perhaps the best way to lower death rate from VTVF after MI, especially in the vast majority who now have ejection fractions better than 35%, will be to do what Northern European countries do, and that is to have mechanisms in place to improve survival of out-of-hospital cardiac arrest. Or perhaps, and I seriously doubt this, but it's possible, the exponential growth of artificial intelligence and machine learning that I hear so much about will help us better predict those who benefit from an ICD. I leave open that possibility, though I'm skeptical. Finally, hypertension treatment. Now, there are papers that are published that will never be Nobel Prize-winning papers, but they still provide incredibly useful data for everyday practice of medicine. JAMA Internal Medicine has published the ARMS, ARMS Crossover RCT from a group at Johns Hopkins. First author, Hairang Liu. One of the most important things we can do during a clinic visit, besides just being with another human being and caring, is to measure their blood pressure. The thing about measuring blood pressure is that it matters how it is done. We're taught the proper way to measure blood pressure somewhere back in our medical education, but then life takes over, right? There are boxes to click, quality measures to fill out, and notes to write. But again, second only to caring, blood pressure measurement may be the most important thing we do in clinic. Now, I have to admit that in middle age has brought this issue into my life. It turns out that I've been fussing with slightly high blood pressure readings and accurately measuring my blood pressure. The authors of this study set out to determine the effect of different arm positions when taking a blood pressure. The guidelines recommend that the arm be supported on a desk with the mid-cuff at the heart level, not resting on a leg or unsupported on the side. Now, we all know this because somewhere, sometimes, someone told us this in our medical training, but then we get busy. The Johns Hopkins team tested the guidelines with a proper crossover trial. Individuals were randomly assigned sets of triplicate blood pressure measures with the arm in 3 positions. The guideline-directed way with the arm on the desk, the arm supported in the lap, and the arm unsupported at the side. Then, to account for intrinsic blood pressure variability, everyone had a 4th set of blood pressure with the arm supported on a desk. Now, there were meticulous trial procedures with these blood pressure measures. Quiet room, automated cuff, repeat measures, walking time, then rest in between sets of blood pressure. A really meticulous-looking study. There were 133 patients randomized. The primary outcome was a difference in systolic and diastolic blood pressures between the reference versus the two arm support positions. The mean age of patients, 57, half were female, 1/3 had baseline blood pressure greater than 130, and about 40% had a BMI greater than 40. So it really was a typical internal medicine clinic in the U.S. The lap and side positions resulted in statistically significantly higher blood pressure readings than the desk position, with the following differences. Get this, on the lap, the delta systolic blood pressure was 3.9 millimeters of mercury higher, diastolic blood pressure 4 millimeters of mercury higher. With the arm on the side, the systolic blood pressure was 6.5 millimeters of mercury higher, diastolic blood pressure 4.4. The patterns were generally consistent across subgroups, except the arm on the side position for patients with hypertension at baseline resulted in nearly 9 millimeter higher systolic blood pressure. Okay, comments. There is much to say about this study. First of all, the findings are similar to previous, less rigorous studies and biologically plausible. That is, if you consider hydrostatics and muscle contraction. So I believe that these findings are real. Second, these are huge effect sizes. Let me remind you that the new and beloved and profitable renal denervation procedures reduce systolic blood pressure by less than these changes over the short term. Third, these findings have huge implications for research using databases from the electronic health record, because while a clinic note of mine may have a little free text at the bottom explaining that the blood pressure is likely overestimated, and it's higher than what the patient reports on home readings, so I'm not going to act on it, yet this overestimated blood pressure sits there in the chart for researchers to use, and this will give a false impression of nature. Fourth, if the blood pressure is taken at the side and we consider the upper bound of the difference, which was 8 millimeters of mercury, I can envision scenarios where clinicians will start or intensify antihypertensive meds that could then cause complications due to low blood pressure. Maybe a clinician has read the SPRINT trial and wants to get to 120 systolic, so they increase the dose of a med or add another one. Okay, now let me speak a bit philosophically. This is a cardiology podcast, and I often deal with highly complex issues like TAVI, or location of a pacemaker, or ablation strategies, or complex valve measurements. But outside of our procedure rooms, the vast majority of what we do is far more basic. As the late Mark Josephson famously said, we are not ablationists, we are doctors. And he was right. No matter how many procedures we do, we are all clinicians who care for people. And few risk factors are more important than blood pressure. We ought to be measuring it properly. We now have rigorous evidence-based data suggesting that doing something as banal as taking a blood pressure could lead to improper treatments. We as clinicians and also our health systems ought to be seeking ways to ensure blood pressure is done properly. It takes longer to do it correctly. It takes investment in education, a place for the patient to rest their arm in a room. It takes effort. This trial argues that it's worth the effort. Proper blood pressure measurement is never going to get on a billboard next to left atrial appendage closure, or TAVI, or MitraClip, or renal denervation, but doing it properly surely is a measure of a health system that cares about health outcomes. Okay, that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And if you like this podcast, please take the time to give us a rating, write us a review. These help others find us. I'm very happy to have feedback. I learn a lot from them. Thank you for that. Until next week, this is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.